Okay, here's our updates for May 3rd. Teleneurology is up and running. If a code stroke is called, the nurse should come and ask you if you want to discuss the case with them, if you want them to be consulted. Um, Apparently, the goal is for them to be able to review the CT, actually see the patient on the video monitor, and then to do an exam, history, etc. Put a consult note in the chart, and then advise us on TPA. They're not there for only stroke, though. They're actually there for any acute neuro issues. So feel free to give them a call for other things, status, or other strange neurologic conditions. If there are any hiccups, let Stephanie, myself, or Brandy, who's the nurse kind of spearhead on this, let any one of us know, and we'll try to troubleshoot alongside you. On that line, if there is an acute stroke called upstairs for an inpatient or a code stroke, there's no need for the ED doc to go because the hospital should be able to manage that. Something we do need to go upstairs for, however, are crash C-sections. So if a crash C-section is called overhead, you'll go to the OB OR, which is on the second floor. Our job is to be the team leader until OB gets there, at which time the baby part of it can be deferred to the OB. And then once anesthesia gets there, you can relinquish your team leader duties and go back to the emergency department. The main goal is actually to help control the room, but most importantly, actually to give sedation so that they can quickly do the C-section. So the goal, or with sedation, the recommended medication is ketamine because it keeps mom breathing. They can just get right in there. So I wouldn't worry about full general anesthesia, putting in an airway and all that. With the crash, it's just get in and get the baby out. And so anesthesia recommends that we use ketamine, and I think we're all very comfortable with that. When you go up there, there's an ED bin, and it has various equipment that we may need, from EKG stickers, blood pressure cuff, pulse ox, to syringes, draw needles. There's ET tubes. There's a blade with MAC 3 and 4. There's LMAs available. The nurse will pull the medication kit, which has ketamine in it, so you can draw it up. And then coordinate with the OB as to when they want you to sedate the patient. Many times they'll kind of just dash the iodine on there, run out and scrub. And so when I went up for one, she said, I'm cutting in 3 minutes. And so I kind of knew when to time that. And so then the next part is you'll be in charge of keeping the mom stable until anesthesia comes and takes over. Many times they will end up intubating mom, depending on the scenario. But right then, again, with a cord prolapse or other big emergency, the reason we're getting called is because there may not be anesthesia in-house immediately. And so that's going to be our job of taking that over. Now, the one other thing is on the crash C-section policy, which I can send out to everybody, it does say that a pediatrician will be called if asked, if the nurses are asked to do so. I would tell you that in my practice, I'm going to call the pediatrician in a crash scenario because it feels like that's a pretty risky time for baby. And if I'm managing mom, I want another doc there to help me manage the baby. The other thing is there are various team members that are supposed to show up. So the house supervisor goes, it's supposed to be the OR team if they're available or they're getting called in. Again, anesthesia, OB. I always take an ED nurse, and they are supposed to be part of the crash team as well, but take an ED nurse with you because they're so scrappy and they're so resourceful that they can be super helpful. So if you want to tour the OB OR and kind of see where things are, I'm happy to take you up there. I'll show you the anesthesia cart, the medication box. In the med box, there should be a key to the anesthesia cart. I don't anticipate you needing very much from there or anything from there because it should be in the in the ED crash bin. On the side of the cart, the BVM is there as well. So again, I'll send out the crash C-section policy, and I can send you kind of this written summary if you'll just take a glance at it. And then I'm happy to take you up to the OB/OR anytime because these can be obviously very, very stressful. They are doing a lot more education and mock codes. I think they had a hyperthermia mock this week in the OR. They're doing more ED codes as well or mock codes, sorry, because of the new nursing staff. So if you're available, the nursing management expressed that they would be really, really grateful for a doc to come as it helps build the team and it helps the nurses to really dig in and take it even more seriously. And it's a really good time for us to educate our team and talk things through, build a little trust, especially with the new nurses. Now, if there is a mock code and things are way too busy, it's understandable if you don't show up, but don't, what did they say? There was an example, I guess, where a doc kind of poo-pooed the process. So try to really reinforce the importance of that education, the importance, especially of the new nurses being involved in that. And if you can pop over and help for 5-10 minutes, it's super helpful. So let's support the nursing educators in helping get these new nurses educated here. Another thing is if there's a AI component on LaunchPoint or on the FirstNet, whatever we use, for possible severe sepsis that can fire during the patient's ED stay. If that alert fires, the nurse is coached to have a conversation with you. If you don't feel like it's septic at that point, that's totally fine. An important thing may be in your documentation at that point in time, if you don't think it's sepsis, but the alert has fired and maybe they're meeting the criteria, as it were, it would be really great and it would save some fallouts if you would time it for that time and then put why you don't think it's sepsis. That being said, we're doing a really good job. Over the last month, we did a great job on our sepsis numbers. We really are complying with the bundle for the most part. There were a couple of fallouts, and they actually were in patients that ended up staying in the ED longer than we would typically have them. One of them was going to be transferred out, and one of them was kind of one of those, I don't know if it's a delay waiting for the night hospitals to come on, or they wanted more workup before they would accept the patient. I don't know exactly what it was, but pressors were not started in a timely manner. So the patient had several hypotensive, both of these cases had several hypotensive episodes, and pressors weren't started in a timely manner. So just keep that on your radar. Start pressors when they're needed. Don't hesitate. That being said as well, we should be getting better midline access. And so hopefully that'll help us to be able to avoid some lines and things that, that take up time and that increase the infection and complication risk, all that. So hopefully we'll have some more support. As far as central lines go, keep in mind that the femoral lines hospital policy actually doesn't allow for those to stay in for more than 48 hours. So they always have to pull femoral lines way faster than IJs or subclavians. So if you can avoid the femoral lines in our facility, it really is better for the patient because then they don't have to have another line placed. So if you're able to place it elsewhere, it would help the patient out. But if it's your only option, use femoral as a last resort. There is a breakdown, I've been told, in the GI, cardiology, and urology referral pool. I guess patients aren't getting put into that pool like they were for a while. So they're calling the clinic and there's some confusion and they're not getting plugged in as seamlessly as they were. So if you guys will remember to go ahead and put urology, cardiology, and GI referrals into that pool, that would be really helpful. So keep doing that. I'll put a little reminder up on the wall. If you're having trouble, ask Haley or Jeremy. We're still missing some suture equipment. We're down 5 kits, so make sure you're not throwing any instruments away. My suggestion would be as soon as you leave the room, try to let the tech know so that they can take it away and get it sterilized. Don't forget to schedule up your dynamic dock training along with Haley and Jeremy so that you're ready for the transition when PowerNote, you know what I'm talking about, goes away in August. There's a meeting called the ED Collaborative. It's a mix of techs, nurses, and ED management. It meets monthly. They're actually making a focus on discharge instructions and trying to prevent bounce backs to the ED. And their concern was that sometimes people don't understand their discharge instructions. So they're making a push there to really make sure the patient understands their discharge. But one thing that they're really focusing on is if a doc puts specifics in there, like types them in or dictates them in, and they're highlighting it, circling it. And one of the things that they're really educating the patient on are symptoms to watch for to trigger their return to the ED. So that was something that they were hopeful we can put maybe a little bit more time or effort into. If you talk to the patient about it, if you'd write it down there as well to reinforce it, and then they'll continue to educate it. And we were going to see if it made a little move on the dial of bounce backs. If there are super delayed transfers out of the ED, like 12 or more hours, please let Dr. Stewart know because we're tracking that. And we are trying to kind of, again, pull together a little bit more as a system. And using some of these examples may help us to better leverage some of our relationships with our other Adventist Health hospitals. We have a new cardiologist that just started, Dr. Hosny. He's an interventionalist, and he is actually going to be starting our PCI program. This month, it is anticipated that we will receive our PCI certification from the state. And we are expecting to actually start doing elective PCI by the end of the month. And also in that time frame, once we start doing PCI cases, we actually will start doing STEMI cases during the week, Monday through Friday, 8 to 5, for the first little bit till we get up and running. And then we have, I think it's 120 days until we have to be a 24/7 STEMI ready or STEMI center. So they'll start getting that process going. And so I'll keep you guys posted with that. It's kind of exciting. We'll be keeping our STEMIs here. One thing we just got from the antibiotic stewardship programs, Dalvance, should only be reserved for those who have failed oral antibiotic therapy, or if they can't take oral medications, or if there are no oral antibiotic options based on the cultures and sensitivities. There is never an indication to combine, or I should say never, but there's really not an indication to combine Dalvance with other oral agents like Keflex or Bactrim. If you guys will let me know, I've noticed lately that the lab techs are canceling some of my orders, like for repeat troponins, for example. Cody today had a pregnancy a serum quant actually that was canceled, and then they decided to do a urine qual instead, which was not helpful. So I'm trying to gather these examples to send to the lab director. It was super helpful because Cody took a picture or on Tiger Text and sent me the orders and then showed where his got canceled and where he had to reorder it. So that's super helpful. If you guys can send that, even send it real time, I don't care. And then that way I can give feedback to the director real time so she can educate her staff. Turnaround time for ESR is going to be delayed for a little while. I guess there's a lab hiccup there. So I think those are all of my updates. I will try to do this a little more frequently. I'm sorry I didn't recently, so that it's less lengthy and boring. But thanks for hanging in with me, and let me know what kind of problems, issues you have, and I'll do my best. Sometimes we don't see results right away with trying to fix stuff, but I really am at least trying to alert people and let them know. One other thing I wanted to tell you is I did have a meeting this morning with the oncology team, and it's regarding POLST forms, and ensuring that their patients really are educated well about their diagnoses. They have a few plans in place to actually tie POLST forms to the consent to treat with chemotherapy for their patients, especially with late stage 3 or stage 4 cancers, which is great. Their plan also is to consolidate their notes a little bit more. So at the end of the note, we can understand what the real time, what their diagnosis is, what the treatment is, who their power of attorney will be, if they have an advance directive, if their treatment's palliative or curative, what the goals were, and then the last time that they discussed those, again, the palliative, curative, etc., with the patient, so that we have an idea real time of what's going on. And then their ask in return was that we just keep them very close in the communication with them. So if you're having struggles with oncology patients, or finding that maybe they're coming in unprepared, please let me know. I really want examples of this so that we can further the communication, give oncology feedback for when we are having struggles with some of our oncology patients. Anyhow, thanks again for hanging in.